Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. My name's Gillian Whiting and we're coming to you from Meanjin, the land on which this podcast is being recorded.
Hello, I'm Maggie Robin, a community GP, rural GP obstetrician at Beaudesert Hospital and coordinator of Mater's GP Shared Care Education program.
In this episode, we're talking about perinatal anxiety and depression with Dr. Majella Henry from Mater Mothers Parenting Support Centre.
Majella is a GP with a special interest in mental health and women's health. She's worked for many years with women and families with perinatal mood disorders.
Majella's joining us to talk about identifying and responding to perinatal mental health conditions.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Majella, how common are anxiety and depression in the perinatal period?
So the Queensland Health guidelines for perinatal depression and anxiety have just come out in 2023, and they have some really useful stats in them. But they quote 1 in 5 women will experience anxiety or depression or a mixture of both in the perinatal, which we classify as from conception up until the first year postpartum. 1 in 10 partners will experience anxiety or depression in that same time. And I think the thing to remember is for about 25% of women, this can be their first incidence of anxiety and depression. So in a time when they anticipate joy or a really exciting period of their life, they can be met with symptoms that are really scary and for them quite new.
A 2022 publication that we will link to in the podcast notes from the Australian and New Zealand Journal of Psychiatry showed that between 2009 to 2015, there was an increase in referrals for mental health care during the perinatal period, while postpartum admissions for mood disorders actually decreased. How do you think we can interpret that?
Yeah, that's really heartening, isn't it? Because I think that what we've always known about the perinatal period is early intervention is key. So that if these families seek support early, that we really can make a difference and work with families in getting them the support they need.
Are there features of perinatal anxiety and depression that set them apart from anxiety and depression at other stages of life?
Well, interestingly, no, Maggie. So the DSM-5 actually to define perinatal anxiety and depression is all about timing. So we use the same criteria that we would with any other patient to diagnose their anxiety and depression. But if it occurs from conception until 12 months postpartum, it is coined perinatal. I think that's really interesting because I feel like it is actually a different phenomena, because for me, whenever I'm seeing a new patient in this period, I'm actually conscious that I've got 2 patients in the postpartum, and always thinking of the patient as a dyad because the mother and baby are so intimately linked and we can't remove one from the other. So we need to treat them as such.
How can you tell it's not what is generally termed baby blues and it potentially could be something more serious?
Yeah, that's a good question. It's actually quite difficult to tease out baby blues versus postnatal depression or anxiety because they actually look the same. So when we're thinking about those early days in the postpartum period, so classically we call baby blues from about day 3 to day 10. So it is time limited. We're not really sure what causes baby blues, but the theory is that pregnancy is a high estrogen state, and within a few days postpartum, those estrogen levels have dropped. And so there's a big hormonal shift. And that we think contributes to feeling teary, anxious, poor sleep. Insomnia is a really common feature. But what we see is that they should alleviate within that week. So from day 3 to day 10, we should start to see a resolution of those symptoms. If we don't, so in fact, and as many GPs will know, to diagnose anxiety, we need persistent, which is at least 2 weeks of persistent low mood. And so if those baby blue symptoms are prolonged, if the distress continues, then that's really when women need a full mental health assessment to see whether actually the baby blues has persisted and we're more thinking about a diagnosis of depression or anxiety. I think it's important to note there are a couple of symptoms that are really prominent in the perinatal period, actually, in depression. And one of those is poor sleep. So the inability to sleep when actually you're feeling very tired can be a sign that your anxiety's up or your depression or your mood is depressed. The second thing is poor appetite. So in a time when actually you have an increased calorie need, sometimes anxiety suppresses our appetite. So you should be tired and you should be hungry is what I always say to mums. And when it's difficult to sleep and difficult to eat, they're really good signs that anxiety and depression are increasing. The other thing that's prominent in the postnatal period is anhedonia. Now, we describe that as a loss of interest or pleasure. And oftentimes, again, as I was saying, when parents are anticipating to feel this to be a really exciting time, they can't find much joy and pleasure. And that's anhedonia and a really strong feature of perinatal depression. In the anxious parent, as well as having the normal criteria of anxiety that is listed in the DSM-5, we actually see a really increased rate of intrusive thoughts. Now, intrusive thoughts are thoughts that pop into our head that are distressing. Some really common ones that women will describe in the postpartum are things like the thought that you'll drop your baby, or being on a deck and a thought pops into your head that your baby could fall over. These thoughts are not thoughts that mothers want to harm their babies, but instead intrusive thoughts that harm will come to your baby. They're really common. They're common in actually most women have described that they have experienced them, but for anxious women, they're happening many, many times a day. And they're causing a lot of distress and they find it really difficult to come down from that high anxiety.
What's the best method for screening for perinatal depression and anxiety, and when's the best time to do it?
So we use the Edinburgh Postnatal Depression Scale, which has been around for many years. It's a really acceptable screen to women. It's only 10 questions, so it can be done really within 5 minutes. It's validated and it has quite good sensitivity and specificity, so it's quite good at picking up who it's worth doing a further assessment on. We usually use the cutoff of an EPDS greater than 12 is worth pursuing a mental health assessment. It is important to note that in the EPDS screen, the question number 10 is a question of thoughts of self-harm. And of course, it doesn't really matter what the score is. If your patient has answered positively to that question, of course, we need to do some safety planning and some further support around that. In terms of the timing of screening, so in pregnancy, we recommend as soon as practically possible. So in the first trimester would be good, and that often falls to GPs to do that screening, but it also through the public health system, through antenatal care, that will be done in the first to second trimester. Then we recommend somewhere in the third trimester, often done around 28 weeks. And as I said, that's done really well. What is still, unfortunately, a little bit inconsistent is postpartum screening. So we recommend that parents are screened within 6 to 12 weeks postpartum, and then again within the first year of life. But really, that screen can be used at any time when somebody walks into your office and you're a little bit worried about their mood or they're not presenting quite like themselves. So we urge, a lot of that work will fall to GPs to be doing those postpartum screening.
A 2018 Australian study involving 1,507 women collected data from pregnancy through to 4 years postpartum. Findings revealed that self-harm ideation was most frequently reported within the first 12 months postpartum, with a prevalence of 4.6%. Throughout the study period, 15% of women reported self-harm ideation at least once, and 7% experienced persistent thoughts of self-harm, indicating chronic distress with potential implications for the parent-infant relationship. While the majority of women with suicidal ideation do not act on these thoughts, it signifies underlying psychiatric conditions, particularly postpartum psychosis, bipolar affective disorder, and depression.
Is there a typical patient who is likely to be at risk and someone that GP should keep a closer eye on?
Certainly, there are some psychosocial risk factors that would make postnatal or perinatal anxiety and depression more likely. these are actually covered in what's called the Antenatal Risk Questionnaire, which is the Centre of Perinatal Excellence, the COPE guidelines, actually recommend that in pregnancy we do antenatal screening to try to identify risk factors that may make anxiety and depression more likely. So some of the things covered in there is a previous history of anxiety, depression, or any mental health disorder. A history of childhood adverse events yourself. So certainly any form of trauma in your childhood can put you at greater risk. An absent or difficult relationship with your own mother or parents puts you at increased risk. Certain personality traits, maybe people who identify as being anxious worriers or have perfectionistic traits. And also current levels of stress, what's happened in the last 12 months. And included in this can be maybe a difficult fertility journey leading up to this pregnancy, or a recent bereavement, financial stress. Of course, domestic and family violence is something that is also worth asking about. Most of those things are covered in the Antenatal Risk Questionnaire. So that it's a lovely, again, a short questionnaire that helps you as the GP actually open up some conversation about what's potentially putting your patients at risk.
What about postpartum?
Well, actually, there is a newly developed postnatal risk questionnaire, and it covers a lot of the same things as the antenatal risk questionnaire, but it adds a couple of things which are really important. One is birth experience. So we know that having a traumatic birth certainly puts women at increased risk. We can also ask in the postnatal risk questionnaire about feeding issues, levels of support. So when mums are feeling isolated and have limited support, that really does increase their risk.
It's also important to include First Nations people. What unique challenges are there with treating First Nations population?
Yeah, unfortunately, as with most mental health diagnoses, the First Nations population, we do see an increase in perinatal anxiety and depression. The EPDS has been modified a little bit, and it's a scale called the Kimberley Mums Mood Scale, which is more culturally appropriate for First Nations women. So I think probably the first tip is that screening we may not be able to use the typical screens, and looking at the screening tools that are more appropriate. We need to really be conscious of asking the question and then following up with what will be culturally safe and appropriate care, maybe through an Aboriginal or and Torres Strait Islander medical centre.
What are the key principles of treatment for perinatal anxiety and depression?
I think we start with the basics. Sometimes as GPs, we want to reassure and normalise, and we need to be careful. In fact, there's a lot of consumer feedback to say that women felt quite dismissed in this period. And I think I don't think it's intentional. I think it's good-natured, but it's kind of those off-the-hand comments like, oh, the first 6 weeks is tough for everyone, or yeah, you'll get no sleep, and it's to be expected. I think that sometimes patients do feel it's minimising their symptoms, and I think it shuts down the conversation when, if we normalise things like women feeling like this is the worst they've felt in their life, and we try to tell them that that's normal, that actually means that they won't seek further treatment. And in fact, we want the opposite of that to be true. We know that early intervention is really, really important. And so we want women to know that treatment is available and treatment is safe and treatment works.
So how would you word that, Maggie and Majella?
So I certainly know as a GP looking after women before, during, after pregnancy, particularly if there's risk factors there, I say we know that the postpartum is the most vulnerable period in a woman's life for developing mental health issues, whether or not she's had them before. And so if you start to find that more days than not, you are not enjoying being a mum, you're not enjoying your baby, you are struggling, make sure you know that you can reach out and ask for help, and it's so much better to do that earlier rather than later, because it's much easier to help you before you've sort of fallen to the bottom of the hole.
Yeah, that's right. And we know that if the symptoms are prolonged and persistent, that the impact on the patient in front of you, the woman, but also her family, is much greater. So we want the symptoms to be for the shortest period possible and to lessen the severity as soon as we can. And in this period, it is definitely worth discussing the role of medication. And we know that for mild to moderate anxiety and depression, that psychological therapies is first line, but once those symptoms become moderate to severe, certainly there is a role for medication, and worth having really open discussions with your patients about this.
What about breastfeeding women? What are the concerns with medication there?
Yeah. Women come with lots of concerns, and we know that unfortunately there is no antidepressant that doesn't transfer into the milk, but we can try to use the medications first line that have the lowest transfer into breast milk. And certainly we would start off with something like sertraline or Lexapro, which we know has a lot of good evidence, effective in this period for reducing symptoms, as well as very safe. I think a really important conversation to have with your patient when you're concerned or they're concerned about medication is that there is a risk of not treating. So if we allow, as we were saying before, depression and anxiety symptoms to go on for a long time, those adverse consequences are far-reaching. A really useful database that I use commonly is LactMed, and it has great up-to-date information on medications in pregnancy and breastfeeding. And so if you need some reassurance, that's often a really good source.
What are the different referral pathways for urgent and non-urgent cases?
Yeah, so non-urgent cases where we sit in that mild to moderate symptoms that is oftentimes managed by the GP. So again, might be a referral onto psychology. Some parents might opt to do some online therapy. So Mum Mood Booster is a common one. The Centre for Clinical Interventions has some excellent modules that people might like to work through themselves. We know there are some excellent websites, Panda, Cope, which provide some really good psychoeducation and can start discussions about management. For your non-urgent patients, this is the time, of course, where if we can, involve families, because it is a real team approach, and sometimes it's really helpful to do some practical things like, could you get more sleep? Could your partner give a bottle so that you could get more sleep? Could mum come over during the day? All of those really practical things that sometimes when you're in the thick of it, you can't see. It's almost like, you can't see a way that things could get better. So urgent cases is when we start to think about how safe is this woman. Sometimes those women can just go to we need to refer them to the emergency department so they get that acute care. We're very fortunate now. 12 months ago, the Mater opened Catherine's House, which is a statewide service for mothers and babies to be admitted in the postpartum for severe mental health issues. And any GP statewide can refer into that service, as well as the Lavender unit at the Gold Coast. And there are some options privately. MH Call is a super useful resource. I call MH Call on behalf of patients with their permission all the time, but patients can also be given that number, and it's a 24/7 mental health service that they can contact. So if it's 3 a.m. and they're feeling really distressed, there is a number there that they can call, and oftentimes then the next day they can organise an assessment.
Majella, thank you so much for joining us today. But before you go, we want to introduce you to our segment we call The Checkup. We want to know more about you as Majella, the medical professional and the person as well. So Maggie's got 5 quick questions for you. They're pretty easy. You ready to go?
We'll see.
Over to you, Maggie.
Majella, do you listen to podcasts? And if so, what are your favourites?
I do. Gosh, this is like a confessional. So I love The Imperfects, I have to say. But for my pop psychology, I really love Esther Perel, who does a podcast on relationships called Where Should We Begin? I love that. And I'm a Chat 10 Looks 3 girl as well, because I just love their book and film recommendations.
I love them.
Me too. Tell me about your first pet.
Oh gosh, my first pet was a guinea pig. We weren't really a pet family, to be honest, and my mum says that guinea pig is responsible for my brother having a parasite and never putting on any weight for many years. So that's my first pet. It didn't last too long, the poor old guinea pig.
What's the best outfit that you've ever worn to a costume party?
You might want to cut this. So when my brother had his 21st, I was not quite, I think I was still finishing school, and he's called Paul, and it was a pee party. And so I went as pregnant, and I just put a balloon under my dress. But during the course, which I thought looked very obvious that I wasn't actually pregnant, but during the course of the night, one of his friends said, I can't believe how well their mum is taking Majella's pregnancy. But thankfully, I held off a lot longer until actually pregnancy was real. So that was the most convincing.
You've nailed that costume, and we're keeping it in.
Fantastic. If you had a day off today, what would you do?
Ideally would be starting off with a massage or a facial, something just lovely and relaxing, and then a long lunch with some girlfriends who I haven't seen in a while.
If a genie could grant you one wish, what would it be?
A bit more time. I feel like, it's the constant busyness, isn't it? That is the juggle of having kids and work and family and friends. I mean, you wouldn't trade it for the world, but sometimes, just a few more hours in the day
would be very helpful. Majella, thanks so much for joining us on sMater.
Been a pleasure. Thank you.
For our listeners at home or in the car or having a well-deserved break between patients, thanks for tuning in.
See you next time on sMater.